Welcome again to Healthcare for Humans. And this is part 3 of our Roots of Care series. You will have familiar faces and guests today. We will break down some concepts and ideas such as polyvagal theory. So I'm excited. Welcome back.
Thank you. Thank you.
Part of my hope for this video was you've been to now some extensive training through both somatic experiencing and compassionate inquiry. You know so many concepts around it. You know how to make it practical. You're both certified in it. But I think everything you say, anytime you say a word, I'm like, oh, I wish I had known more about that. And I want to dig deeper into these concepts that are potentially foundational to using a tool with somebody else. And underlying both compassion inquiry, I think, I don't know enough about it, but somatic experiencing is this idea of polyvagal theory, which you've touched upon a little bit. And I hear it a lot. And it's something that I think is probably foreign to a lot of clinicians on what it is and why it's helpful. So first, I would like to, in the best way you can, how would you explain polyvagal theory?
I want to couch this by saying I don't in any way feel like I'm an expert in polyvagal theory, but I think it's something that's been idea and concept that's been really influential for my own healing. And I think really influential in how I think about caring for patients. So the idea behind polyvagal theory is that our nervous system is wired to help us survive, and that our nervous system is divided into this hierarchy of different parts. And so we have a social engagement nervous system, and that's the part that kind of involves our facial expressions, our vocal prosody or the up and down range of our voice. It involves the muscles in our ears that allow us to kind of tune into different frequencies of sound. And that part of our nervous system is innervated by the ventral vagal, so the ventral part of the vagal nerve. And then we have our sympathetic nervous system that, as physicians, we're very familiar with this idea. So that's our adrenaline, fight, flight part of our nervous system. And then I think the concept that polyvagal theory really introduces is this idea of the vagal nerve being divided into these two parts. So there's this ventral vagal that I talked about already, and then there's dorsal vagal, which is really what's running more into below the diaphragm, into our gut. And that's the part of our nervous system that, when we are safe, can help with digestion, but when we're in a survival state, can bring us into a kind of deeply shut down, disassociated state. We can talk about this in more detail, but I think what the theory really posits is that all of these are adaptive, functional states. Ideally, when we are safe and healthy, and we can mostly exist in this social engagement nervous system, but it's normal that we're going to go into moments of sympathetic drive. We're going to go into moments of shutdown, and that's kind of that variation that happens throughout the day. But what happens for many folks who experience trauma, and that can be in large and small ways, we can move into a home away from home where we actually end up existing a lot of the time maybe in sympathetic or maybe in more of that dorsal vagal shutdown. And each of us tends to have one that we go to more easily. If you're spending a lot of time in one of those states, that can manifest in different ways. But I think if we think about it as family physicians, like in a clinical setting, someone who's tends to go towards that sympathetic nervous system might be someone with hypertension, with anxiety, with insomnia. And someone who's maybe spending more time in that dorsal vagal shutdown, that might look like fibromyalgia, irritable bowel syndrome, chronic constipation, depression. And so it gives a lens to understand how we move through the world, but from this point of view of our nervous system functioning. And I think another important part of that is our nervous system is constantly assessing our environment for cues of safety, and it reacts in these ways, in automatic ways. So it's not conscious choices that we make to move in and out of these states. And it's not like being in a certain state dictates exactly what you're going to do, but it's going to offer a range of ways of reacting. And so if I'm in a dorsal vagal shutdown, I may not have access to, let's say, creativity or imagination or more expansive thinking. Well, I want to pause there and just see what you would add.
When I think about the nervous system, one of the things that comes to my mind is in medical school, there's a anatomy textbook called Netters, and there's all of these pictures of different organs or different systems within our body. And there's one of the vagus nerve, and it's just kind of going to everything. And it's just interesting to think of what's happening inside as far as there's so much communication from our organs back to our brain, and we think it's obviously there's also in the reverse, but we don't really think about like how we're getting that feedback from our body and how that's informing us as to how we feel. And I think res momenticum is called the vagus nerve, the soul nerve, and I think it's vagus. I think this comes from the idea of the wandering nerve, maybe because of how it is shaped. And for me, a lot of these ideas, polyvagal specifically, comes from Stephen Porges' work. And it's another one of those examples of some people argue with this theory, but I have found it to be like a really helpful framework to understand what I'm witnessing, even to understand my own system, like what's happening for me. So the three of us just ate lunch. And so we're digesting, and dorsal vagal, I think, can have that rest and digest, but it's like which aspect of it? There's an aspect of rest and digest, and then there's shutdown, which is so we want to be slow. We want to have access to being in a rest state where we are immobile or resting, but we know that we're safe. But sometimes if an animal is threatened and if they tried to fight and they're unsuccessful, and they've tried to run away, they've tried to fight back, then they may freeze and shut down. And so if we're immobile and we're frozen, but we're totally shut down, all that activity from when we were going to fight back, it's still there. It never really fully was successful. And then we've just shut ourselves down on top of it. So often, while we may be frozen, there's all this other stuff that's there as well. I definitely spent a lot of time frozen in my life. And I think even as we talk about freeze, you can start to feel it. It's kind of if somebody's talking about itching, you can kind of start to feel like a scratch. And so
Gosh,
I could
there's
definitely
so many
share.
places I itch. You're right.
Yeah. So, I mean, we could share more about how do I experience freeze? How do I experience fight? Or how do we see those things in our patients? And I would want to ask, I guess, since you were saying that it's something you want to understand more, as we've said a little bit, is it feeling like clear as mud? Is it feeling like there's more things that we could explain? Because you were sharing earlier that you don't have a lot of context for this. So I think that's actually great because then you can let us know, like, how is it landing when we're explaining it and what else can we help you understand?
Yeah, I'm imagining somebody listening. I'm also listening. And I think there's a part of me that's skeptical. I think of this idea of all models are wrong, but some are useful.
Sure.
So I want to focus on like how useful it is. And I think you brought up something before of practice-based evidence and versus evidence-based practice. Not that they're against each other, but it's not helpful to think of why isn't polyvagal theory more widely publicized? I don't remember reading academic journals. We don't research about it. So like tending towards like, how is this, woohoo things that there's not evidence for. And I don't know if it's helpful to go down that path. And that might be just me, but I do feel like in mainstream medicine, things get dismissed too quickly. So I just want to speak to that a bit and pivot the conversation to what is useful about it. So your question on what has resonated with me is having potentially another model that feels useful in situations that I'm often struggling with or don't have answer, or don't have an explanation. It could be, you name specific conditions, irritable bowel syndrome, chronic constipation, could be depression, whatever it is, it's the biomedical model seems imperfect to explain what's happening. Neither the patient nor am I satisfied with it. We're like, irritable bowel syndrome, here's a diet to help you, which is very restrictive. Why is it happening? I don't know.
Yeah. So for my own healing process, I would say for myself, a lot of the way that I dealt with overwhelm in my life, not conscious, this was an unconscious response of dissociation or freezing in such a way that, like, basically it's like I'm here but I'm not here, and if I really can't see others, they can't really see me, and so it's a way to stay safe. That was not my thought process as a 4-year-old, but I can understand that now looking back. And in recovering from that, I experienced that first more in the kind of more gross movements of my body. If there's a situation that's going on that's really maybe a conversation I shouldn't be engaged with, for example, being able to be like, well, I'm done with this conversation and stand up. I mean, that even just feeling your muscles getting up, having that urge of like, I'm going to leave and being able to do that. If you've had a flight response that's been thwarted in the past, you might not have access to that feeling of like, I can get up and I can move. There's also a deeper level. So you can have freeze in your viscera, it can be that deeper within your gut or within your joints or in your diaphragm that you can be frozen. This is something that, yeah, a lot of doctors would probably say, well, that's woo-woo.
Yeah.
But
Is that what it? Woo woo. I said it wrong.
you said woo-hoo.
Yes, I know.
I
That's a
don't
big.
know, or woo or woo-woo, doesn't matter. Like,
I get idioms wrong all the time. I was like, it doesn't sound right. Sorry. Go
whatever.
ahead.
Well, I don't say that, so I don't know what they're saying, but
Who sounded way too positive when it came out of my
we'll
mouth.
go with that. But yeah. So yeah, and even being able to laugh and feel the resonance of that coming up from deeper inside yourself and out. If you're in a freeze state, you can't really experience that vitality of life. It's also important to consider what's the bigger reason that we're talking about this. And it's so that people can live. And when people are just surviving, that's wonderful. I want people to survive. I really want them to be able to live the breath of life, to really engage. And so the goal is the more that we can build the capacity to be in that social engagement system, that ventral vagal tone, really to be able to look in somebody else's eyes, talk to them, feel your own voice, dance, play. That's why these things matter.
Yeah, I feel like already I'm thinking of situations of connection. There's a feeling of separateness when you're taking care of people. And the polyvagal theory makes me feel more connected to the person next to me. And even the idea of resonance and energy and vibrations, being careful of how those language is used for selling supplements, etc. But there's a connection that's in between us right now. And even when we just laughed,
Yeah.
like it was like a feeling that changed our connection, that probably affected our nerves.
Absolutely.
And maybe changed how we're receiving information going in this next few minutes.
Absolutely.
And the rest and digest, I feel a little more activated. I don't know, like there's something that changed, right?
Yeah. Before I went on this healing journey, it was more feeling that type of energy. For example, I like to exercise, and I would go to an exercise class and I would feel my heart beating and I would just start panicking because I associated feeling that with fear. So I realized after a while that once I was able to recognize in the here and now, I am safe, and my relationship with my own heartbeat changed. I can feel excitement, which can feel similar to fear, but it's different. That is really what I think, Peter Levine's work is trying to help people do, is go from paralysis and fear to excitement and curiosity.
I think it's true. And I'm bridging all these other things that are randomly coming to my mind on how I think there's some research out there that says many, specifically men, grow up with such few vocabulary for emotions, just often feel bad or feel good. And that naming emotions is actually a skill that can help you be more self-aware. But taking it to the next level, there was this research that people talk about a lot, which is they did this social psychology study. I don't know if it was replicated, but they had people meet different partners on top of a bridge or at a regular, a restaurant. And people thought they liked the other person more if they were close to a bridge because they were actually scared. I don't know what the location was on a bridge or whatever, but They were like trying to jump off.
Studies,
Yeah.
like, why are we studying that?
I don't know. But I think the key point was that your heart beating faster could be seen as fear or excitement for this other person. And it was
Right. Yes.
contextual.
Yes. Yeah.
And they interpreted it as, oh, it was probably because I was excited to see them. So I liked them more compared to it was because I was on top of the bridge and my body was like, you know, it's a
Yeah.
little on edge. But I think it's both like naming it, but also self-awareness of what am I feeling and why am I feeling this? Sometimes it's hard and people cross wires a little bit about that intentionally or unintentionally.
I think what you're naming, there's a difference between like emotion and like physiologic nervous system state. And that's something I think that's been really helpful with polyvagal theory. Like I'm not a neuroscientist to adjudicate like how totally correct of a model this is, but I think it has felt functionally very, very helpful in my own healing and also in understanding other people. And I think that distinction between, okay, I'm in a sympathetic state right now. My heart is racing. Maybe I'm sweating. I feel a little bit flushed. And that is different than emotion. And so there could be a number of different emotions present there. And oftentimes we're not consciously aware of what cue led to that state. You know, there could be many things from our history. There could be subtle things in the environment. Like Stephen Porges talks a lot about low frequency background noise. So like we're sitting in a room with the highway sounds in the background. And so like that may have some effect on our physiological state. But then we have that heart racing. And on top of that, we add a story of, okay, and that story is probably influenced by our history. So, okay, my heart is racing. One person might say, okay, that means I'm excited. And someone else in a different context might say, okay, that means I'm afraid. And so that's often what we actually catch in our consciousness is the story. And I think polyvagal theory offers this window to say like, oh, wait, but what's actually just this physiologic state without having to add meaning to it? Or it gives you then the option to choose different meanings or in that awareness, okay, I don't have to feel afraid every time my heart is racing. I can just recognize this as simply, this is a state that I'm in. My heart is racing.
Yeah.
Yes. Sorry, I was going to say that in medical practice, we focus a lot on story. What is the story being ascribed to these symptoms? I think that it's very important to listen to the story. Also to recognize, though, that we have to listen to the body's story. Part of what that entails is just getting to know those sensations and being able to follow them and see, what is this? Where do we go with this? And I think in medicine, we're like, okay, arm hurts, x-ray, or it's very like, this is the problem, so we're doing this, versus with, for example, somatic experiencing, there would be a sensation and perhaps just staying with it, see how it changes, or see with when you notice that sensation, is there an image that arises? You know, meaning or story is not necessarily bad, but having more curiosity, more vocabulary around the sensations themselves, and understanding that a lot of the stories that we have associated are kind of the understanding of a child, the understanding that we've made of that maybe we didn't have the full picture, or a traumatic event happened and we didn't really remember all of the things that happened. But as we can get support and follow the body's story, a new story often emerges on its own. A new meaning emerges as we can get to know our sensations more, as we work through perhaps things that were unfinished business within our body. You know, in the example of myself exercising, you know, when I would exercise and I would feel my heartbeat, it was like, well, I'm in danger. And then I would think about all the other things that were stressing me out. You know, the exercise, the trainer could tell, like, I'm not here right now. And I would be just totally glazed somewhere else. And so through working with that now, when I feel my heart beating, like it's very pleasant and has new meaning to me, like I'm alive. I'm strong. But when you're traumatized, I think a lot of times people try to apply that new meaning versus arriving to it through doing this work and letting that new meaning arise on its own. Our work in medicine is very different than that. We apply the meaning from the beginning and we don't really get to see how that story evolves within the body.
It's so interesting. We have all these stories because we interact with humans and this idea of clinical care of how often I am placing a meaning on somebody else's symptoms. That knee pain is because of the arthritis,
Oh, yeah, that's a big one. Yeah.
right? That back pain is not because of the arthritis. With like this idea of so many people have problems in their back x-ray, so we don't need to get it. That's not probably the cause of it. I'm attributing the meaning to their symptoms and trying to explain it. And there's this dynamic I establish of I am the meaning maker for what your symptoms
Right.
are. So it's especially a feeling of let down when somebody has symptoms and I don't have a meaning for it. Irritable bowel syndrome. Why am I getting this? And I've had recent conversations on just different symptoms where there is no clear why. Like, why do I have this rash? I don't know. And trying to figure out a meaning for it. So that's one piece of it. The second is I do think it's freeing to separate the emotion from the physiology because anytime I've been trying to feel like, what am I feeling right now? We talked about anger earlier in the prior episode and frustration when we're taking care of patients. But often I can't identify the emotion. And I'm like, I'm supposed to name it to tame it. But what am I naming? And like, where is it? Like, what is it? But often it's just a sensation that's vague. Like, oh, I feel if you pay attention enough, really tight in my shoulders and constrained. And I have no idea what the naming is, but I know I don't feel open. That's all I can end up with. So then often if I don't feel forced to name the emotion, if with this theory at least, it frees me to say, well, how can I still care for myself to get into a more open place without feeling so stuck on, is this anger? Is this resentment? Is this frustration?
Yeah, even right now, it's
like, do you see that? Like,
so as you do that, as you do that,
yeah,
what do you notice inside?
just like pressure, I think.
Yeah, where's the
Like,
pressure?
in the middle of my chest and weirdly in my calves.
Great. Okay.
Yeah,
Does it feel tolerable?
I think so.
Can you stay with it
Mm-hmm.
and just notice how it changes?
Mm-hmm.
What did you notice?
There was eventual dissipation of it.
Oh,
Like
interesting. I saw you take a really nice breath. It looked natural.
I don't think I planned it. Yeah, it just
Yeah.
happened.
Yeah. And how do you feel now?
Better. Yeah.
What's better?
I think a feeling of was pushing up against something. I don't know how else to
Yeah.
say it.
Yeah.
And I didn't have to do that any longer. It was almost automatic reaction, I think. And probably some story and thought that I'm still haven't processed. I don't know. I feel like now I'm making up things. Whenever people ask me to make sense of it, I'm like, this, maybe that.
I mean, it's a different way to
Yeah.
speak, it's a different language, and it's very different than the language that we're used to.
Yeah.
I was working with a patient the other day, and I've been working with them for quite a while now, like a couple of years. Initially, their presenting symptom was chest pain. So we did the initial workup of seeing cardiology, ruling out other issues, making sure like they're medically safe. Then we started working with building this vocabulary for what's going on inside the body. One of the things that we realized is they don't only have chest pain, there's a lot of tension in the shoulders, in the back, lots of pain, panic attacks. Is one of the things that is there on their chest is grief. And what we learned recently is one of the reasons they haven't been able to really touch into that is there's also a lot of anger. And that anger was unsafe to express. When we met recently, they did kind of a similar motion to what you did, but I think it was more like with their hand outstretched, like almost as if they're pushing against something. And to me, they looked pretty grounded in the moment. And so I knew that it was like okay for me to engage with that some more. And they also made this sound like almost like I don't want to say a growl, but almost like a little bit of a scream was coming out. And I offered my hand for them to press against and offered that they could look at me, press against my hand, and we could slow that scream down and engage in that together. And so we're just sitting there in the clinic, growling, just pushing against her hand against my hand. And this was an opportunity to, in a safe way, feel anger that hadn't been really felt probably their whole life. I recently attended a screening for a film that my friend made. It's called To Dress a Wound. And my friend Jenna Hanchard, she made this film where she'd written this poem postpartum. And there's so many feelings that come up after you deliver a baby. And all of us have done some amount of perinatal care. And I have kids. One of the themes that came up in this poem that eventually became a film was all of this unexpressed anger for herself, but also transgenerationally, anger that could not be expressed. And some of the people who came up on the Q&A were talking about, one person was sharing about like having had something in their throat. And this is such a common complaint we get in primary care. There's something in my throat. There's some sensation here. And for many people, that anger or something that couldn't be said, something that was unsafe to express, is stuck. So when I hear about symptoms, I feel way more curious than I used to be because I have more questions to ask. When you feel that, is it in certain situations, or what is the quality of it? What is the color of it? What does it seem like it wants to do? As you're talking about that, how do you feel inside? How is it changing? It's just allowed me to really engage with what people are feeling beyond just labeling it or saying, yeah, sometimes we don't know, but that I don't know is more, there's more curiosity around it. Like, I don't know, and let's figure out together, like, what is this that needs to move through you?
Interesting. Yeah, it seems like polyvagal theory allows you to access curiosity in situations where, at least in the current paradigm, it feels like you're at the limits of your knowledge. People handle that differently. It could be in the most generous, like, I don't know, let's just talk about the treatment or what we can do, versus frustration or whatever emotion that comes up when you're at the limits of whatever traditional medicine gives you. So even understanding this allows you to explore more potentially, right?
I think it's an opening to curiosity
Mhm.
and something that's been really life-giving to me within polyvagal theory, and I think a lot of somatic work, is that like everything has meaning. So we might say, I don't know the medical diagnosis for this pain that you're having, but it has meaning in your life. There's a reason it's showing up. And it's not about that analytical, we need to think really hard and know that reason, but like can then be with people in that space of
Mhm.
understanding like what's going on that this is showing up now. And I think this can sometimes feel like a harder leap. And I'm still working through it for myself, but also understanding it all has adaptive function
Mm-hmm.
too. And that might not be where you start with a patient, but if you're coming into encounter with that idea of like, in our last conversation, we were talking about high blood pressure. What is this high blood pressure trying to communicate? What is this fact that you're in this sympathetic state communicating? Is there something that you're needing? Is there something you're like needing to work through? Is there something happening in the larger world that's landing in your body? There's a reason that's showing up, and that has like, there is something adaptive there, even if it's actually in this moment causing harm. And so that I think that gives a different way to think about how do we understand a symptom that someone's coming in with. And then it also offers a different, so much of Western medicine is about suppressing symptoms. Like we want to treat the high blood pressure, we want to treat depression, we want someone's pain to get better. And I don't think that's bad, but I think sometimes in that we miss, what is this actually trying to communicate in the first place?
I mean, one thing I'm taking away is noticing helps. Like you did that for me. Just noticing people's reactions and body movements
Mm-hmm.
as a way also to connect to polyvagal theory, and that it's not just what they're saying, but how they're saying. And sometimes people narrowly interpret that as with their voice and emotion, but it's actually with their bodies too. And it's what's trying to express, right?
I think that tool of being able to recognize, okay, this person is in a sympathetic state, or this person is in a dorsal vagal, like shutdown state, is a really helpful tool. And I think like in my own journey prior to encountering polyvagal theory, like I don't think I'd heard it talked about in a meaningful way that one of the ways we respond to stress is through shutting down. And that's definitely like that's where I go to. And so I've had a lot of interesting experiences of my life of people telling me like, "Oh, you are so calm under stress."
Hmm.
And that's not my internal experiences. Like what I'm feeling right now isn't calm exactly. It doesn't feel good, but I didn't have a name for it.
No.
And so I think polyvagal theory like offered this name of like, okay, actually what's happening is that like I go into a very deep dissociated shut down place. And when people perceive me externally, they see like I'm not in sympathetic. I'm not agitated. My heart isn't racing. I look calm. And so it's been really helpful to have this language to name that state. And I think it's really helpful people who've experienced trauma, it's not uncommon to go into that shutdown state. And I think there can be a lot of shame around that of why didn't I fight back? Why didn't I run away? Why didn't I respond in some way? And so I think holding that, your nervous system made this choice for you to shut down because that seemed like the best way for you to survive. And so I think it offers this window into compassion and gratitude for what often can feel shameful. And it also offers this understanding. I saw a patient in clinic the other day who was saying like, "Oh, I'm not stressed. My heart rate monitor isn't telling me I'm stressed." And I'm like, I wonder if your heart rate monitor is interpreting stress as being a elevated heart rate.
Mhm.
But if you're someone who tends towards shutdown,
Mhm.
like stress for you actually might look like slow heart rate and low blood pressure, but we don't have vocabulary for that. I think for a lot of people, and I don't know if this is more true for women. I sort of wonder if it is because there's more social pressure to not act out in anger.
Mhm.
Mhm.
It's like we don't understand that as being a stress response.
I think I wonder about that because they say that the inattentive ADHD is more common in women and the hyperactive is more common in
Yeah.
boys, men.
Yeah.
Is it a disease or is it something that there's this rush to label things without understanding more deeply what is the pattern? And I know we talked in the last episode about how validation can come from that and how people definitely need to receive the care that's appropriate for them. But what we're talking about is understanding more the person and the patterns, and that someone's state can change. And patterns that have been very long standing, they can change. And it doesn't mean that I think there's so much societal expectation that you're going to be a very specific type of way. And that's not what we're talking about. It's more like, how do we, given what you've been through and how you have responded, how can I be here with you to help you to live more in the way that you want to? And so, not judgment in these states. It's more just, yeah, curiosity and describing and trying to see where we can go with this information.
In the last episode too, we talked about how some patients come in and if they have high blood pressure, they name the structural factors that's causing them to have high blood pressure. And they know it's connected to their bodies and their nervous system. I think sometimes patients actually don't fully recognize it. And I wonder how you introduce the topic. We've touched on it before, but is there any not practical, I don't love that word, but tools that you use with patients to bring up this idea of polyvagal theory in whatever manner, so then you can shift to, I've done all the workup for chest pain. It's not heart related. We're shifting to this different topic now. Or fatigue. I feel like that is also a place where people get stuck a lot. All your lab work is normal. I'm not sure where you're fatigued, but maybe you're pivoting to a different topic that maybe they aren't fully in agreement with. You have to figure out where they're at. They want to do more testing or they're looking for answers.
Yeah, I'm going to explain one other
Yeah.
thing first. And then, so if I forget to come back to the
Yeah.
how do you explain it to patients, then please remind me. But we talked about fight, maybe briefly mentioned flight, but we could come back to that
Yeah.
later. And then we definitely talked about freeze. But one other response is appease. So, one article that is really helpful to read, I think it's titled When Agreement is Not Consent, and it's written by Nkem Mendefo and Ray Johnson. It's on, so you can Google it, it's available online. They tell a story of this group of Black women, their friends on vacation, and they're at an Airbnb and they're leaving. And a white woman who lives across the street sees them load suitcases into their trunk and tries to wave to this group of Black women. And I guess they don't, in her perception, they don't wave back. So she calls the police. And the women have left. I think they're like en route and they are stopped by the police. And I think the incident was recorded. I haven't watched the video, but the police were saying, well, when we stopped these women and we were talking to them and questioning them, they were all laughing. And it was a very friendly, professionally handled situation. But later, the women who were questioned, they shared that actually they were feeling a lot of other stuff. They were scared, angry, humiliated. Like, I don't remember all of the emotions that they described, but there was a lot there. But they had been trained by society, and especially in the situation of facing a police officer, that this is the way that you need to appear if you want to survive. And so this is not something they did consciously. It's probably something that's been learned over generations to just do automatically. And having to respond in that way to survive, that takes a major toll on someone's, the energy taken to suppress your natural responses takes a toll on your health. In working with patients, because often people who deal with more social issues or more sick. There's a wonderful documentary called Unnatural Causes and many other studies that have shown this over time. But, whether it's race or it's poverty, and the ACEs study as well. So when we're working with people, often the people that we're working with that have these syndromes, they have dealt with either structural issues or other types of trauma. So it's really important for us to understand how that impacts their health. But in coming back to how I explain that to people, is really first understanding like what they wanted when they came in. So some people, like, literally all they want is they want some blood work today, and that's it. And so if that's the case, I try to clarify pretty early what they want. Some people are not sure what they want, which I think is I want to say that's also part of trauma too, of just like either being traumatized by the medical system to think you have to listen to the doctor, or no one having cared about their opinion over time, or even just like the lack of connection with self and our own desires is part of what we lose when we're traumatized. And so helping them find within themselves, what is it actually that I want? I was seeing someone the other day and I asked, I think 3 different ways whether they wanted this follow-up appointment with someone. And each time they kind of went back to something else. And so just being able to just even engage with like, what do I actually want? It's kind of helping them. It's part of the healing process. And as a part of that, I also often ask, like, can I explain more to you about how this, like a more wider view of understanding these symptoms? Or maybe they're asking me, like, why is my blood sugar high? Or why do I get this migraine? And I'm like, well, we can talk about that. And I explain a little bit and then ask them if they want to know more. And if they want to know more, then I explain more. But it depends like where someone is on their journey and whether or not they are interested in looking at it in this way or not.
For sure.
Maybe I agree with all of that. And I think maybe I'd just add, I think it's rare that I'm like teaching someone about polyvagal theory. Maybe that would be a lovely thing to do, but that's not generally what I'm doing in clinic. But I think validation as a tool is really beautiful, and really believing that in yourself, like you're fatigued for good reason. Like there are good reasons you are tired right now. And I think sometimes that's like enough of a conversation for folks. Like, of course, you have young kids, you're caring for your parents, you're working, and your job is stressful and your marriage is stressful. And I think sometimes just holding that, and it's, yeah, of course, your body is tired. I think it can be so important to hold that space for it and honoring it's not because your body's against you. It's like your body's really trying to communicate something here.
I like that as something that everybody can do. We don't do enough of. We talked about a little bit about fight. We talked about appease, somewhat about freeze. What does flight look like when you're caring for people?
Yeah, I mean, I think in a clinic room, you can imagine that patient who's more aggressive, who's maybe getting angry, who's pushing back against you. And of course, having, I think, the wherewithal to be like, oh, this is a nervous system response. It's not personal, and it's actually probably it has served a function in this person's life. There's a reason they're showing up with that. I can think of like one particular patient I cared for a long time who's an older man who I came to like over time, but was really challenging for a lot of people, because he would always come in ready for a fight. And it's like you over time learn he came from this very dysfunctional family and like probably never was like taken very seriously. And so that's how he gets through the world, is coming kind of ready to fight for whatever he's needing. But I think flight often is more subtle, and that can often show up as people getting quiet. It can show up as people kind of just going along. It's like their agency and self sort of leaves the room, even if they don't literally walk out.
Okay.
So that sense of them, oftentimes I think that shows up with them just kind of going along with the plan, and then they leave and maybe don't actually do any of the things that you suggested.
Yeah.
Yeah, I definitely, when I was mentioning earlier, like me not really getting up and leaving a conversation, for example, often when there were situations that were difficult, I experienced flight internally. Like I would find myself in a situation in my mind that was, almost endorphin producing. And that was, for me, often was associated with some amount of freeze too, because I was not leaving. So in some ways it was like mobility wise, not fleeing, but in my mind I'm fleeing. But I also think of people who I've met who they can't quite sit down. I mean, that could happen for a lot of different reasons, but in some situations, I wonder about restless leg or different types of nerve type symptoms that people get in their feet. And again, I wouldn't categorize all of these as that, but definitely paying attention to like what's going on with the feet can be one area to get curious about, to observe. Is there a kind of thwarted flight response that needs to be worked with? And even for people who have disabilities and maybe can't run, even just imagining doing it can be really helpful. So the patient that I mentioned who was expressing their anger, there was a moment where a little while after that where I wasn't sure if maybe there was some type of flight response showing up. So I invited them to get up and walk. And so we took a nice little loop around the clinic area. And it was amazing seeing how they shifted from all of this. There was some agitation that was there. And then they were observing the art, like, oh, tell me about this one. Or, oh, do you know about this artist? Because we have this beautiful artwork on the walls. And so that social engagement system, that curiosity, that ability to see the environment was really active. And so for other people, if somebody is like really not wanting to be there, can they honor that and get up and leave, or, and know that like, hey, I'm still going to be here. You can go and you can come back, not in a way of like you're kicking them out, but you could even accompany them, or they could imagine running. I think there's a lot of really interesting things happening with those type of responses. Yeah.
Yeah, the other thing that came to mind is this like psychological scattering. Like we've all had the patient where it's like they're just all over the place. It's like they can't stay
Yeah.
in one story or one. And I think that is a form of flight as well. It's like their mind is scattered.
Yeah.
And of course, there's so many patients who also just don't come,
Yeah.
or they
For sure.
come and they don't come back.
Yeah. That's
Um,
interesting. We could talk about this for a while, but I think I feel like I have at least a better grounding
Mhm.
on polyvagal theory and its utility and how useful and helpful it can be for folks, and understanding some of the other topics we talked about too. If people wanted to learn more, I know you both were trained in different modalities, but perhaps connected to polyvagal theory, where should people go to get started some deeper training if they want it?
I would say that I haven't read Stephen Porges' book, Polyvagal Life, but I heard that it's easier to read than his other books. But I have watched many videos of him on YouTube.
Mhm.
For me, it's much easier to understand. There's a lot of short clips online where he's explaining his theories and some that are longer interviews that are really helpful. If you have the ability to attend a training, I really recommend the Somatic Experiencing program. If you can't do the whole 2 or 3 years of it, like the entire training, I would really recommend doing at least the first year of it because you would just get the first 3 modules, which would give you a good basis and a lot of this information. And then you mentioned Deb Dana. I have not read her whole book, but some people have mentioned that's helpful. And then I really like Kathy Kane's book, Nurturing Resilience.
Mhm.
And I'm currently reading Tao of Trauma. That's by Elaine Duncan and Kathy Kane. And I'm reading it just a little bit at a time because each page is like a lot of nuggets in it. And so I would really recommend that one. And then, yeah, you can see videos of Peter Levine on YouTube. There's a lot of clips of him talking about these ideas that I find super helpful. That would be my initial recommendations. I don't know, Rachel, what you would add?
Yeah, I don't know that I really have too much more to add on top of that.
Yes.
I would say go see a practitioner who's
Well,
trained
yeah, that's a good.
in
Yeah,
somatic
and
experiencing.
feel the difference.
Yeah. Yeah, because honestly, learning it on yourself is going to be more useful than any book that you
Yeah.
read.
Thank you
Thanks.
again.
Yeah.
Let's see.